Good evening, everyone. I welcome you all to the first therapeutic forum of the year 2024 of Sri Lanka College of Internal Medicine. This forum was initiated to uplift the knowledge and the practices of the practicing physicians. Without much ado, I would like to invite Dr. Suranga Manilgama, President of Sri Lanka College of Internal Medicine, to address the gathering and welcome the speaker.
Thank you, Ranga. Good evening, everyone. I welcome all of you to the virtual meeting, and this is the first therapeutic forum of the year. And so therapeutic forum was first introduced in 2023, where an expert in the field talk on a topic relevant to the physicians. So which helps to enhance the knowledge as well as the practice of the physicians. Our theme of this year is envisioning the future, empowering the physicians. So definitely this will empower our physicians. Today's topic is on non-vitamin K oral anticoagulants. Also, we call it directly acting oral anticoagulants. And even though it has been available globally for some time, it is a new topic to hear, and now only it has become popular in our country, and the few products have been registered and available in Sri Lanka. The special thank to our distinguished resource person, who's Dr. Manu Wimalachandra, so for sharing his expertise with us today. And I extend my heartfelt gratitude to our coordinator, Dr. Ranga, for his excellent job. And I appreciate all of you for joining with us today. And I appreciate the technical support given by Gates Pharma for this academic, the virtual academic program. And without much ado, I invite again Dr. Ranga to introduce our speaker today, Dr. Manu. Over to you, Ranga.
Thank you, Dr. Suranga Manilgama. Our speaker today is Dr. Manu Wimalachandra. He's a consultant clinical hematologist and senior lecturer in the Faculty of Medicine, University of Colombo. He received his hematology training from the National Hospital of Sri Lanka and King's College of London. He is the current secretary of the Sri Lanka Clinical Trials Registry and Clinical Trials Subcommittee of the Faculty of Medicine, Colombo. His areas of academic interest include bone marrow failure syndromes, hematopoietic stem cell transplant, and acquired thrombotic disorders. Over to you, Manu.
Thank you, Ranga, and thank you, Dr. Suranga, and thank you for giving me this opportunity to talk about this topic. So I'll get straight into it. So I have titled this topic as DOACs, not a panacea for anticoagulation. Like Dr. Suranga said, DOACs have been available for the past 2 years. Not freely available, but it's getting available to our physicians. And I think it's important once we start using them that we use it for the right purpose. So this is the outline of my talk. The initial first few minutes, I will spend about what DOACs can do, what they can't do, and what we think that they can do. The last bit is a topic which I have done previously also about my approach to starting a patient with DOACs. So I apologize if it's a bit of repetition for some of you, because I know the audience would have, perhaps would have heard it before. Right, so just to recap very quickly, the first oral anticoagulants came into practice in the 1950s in the form of warfarin. And for a good 50 years, we didn't have any oral anticoagulants besides warfarin until the Wimalachandra came in the early 2000s. It was rapidly taken off the market because of its hepatotoxicity. Then from 2009 onwards, we have been seeing the emergence of these novel anticoagulants. So dabigatran, rivaroxaban, apixaban, edoxaban, and betrixaban are the ones that came out. So the term initially was NOAC because it was novel, but then it was novel anymore. So they started calling DOACs. But some people still call it NOACs to mean non-vitamin K antagonists. So there's two mechanisms of how the DOACs work. If I can get your attention towards this diagram on the right side. So this, you have your intrinsic pathway and the extrinsic pathway. Either way, you have your factor 10 getting activated in the presence of factor 5 and calcium, and that converts prothrombin to thrombin. So dabigatran is a direct thrombin inhibitor and inhibits thrombin, whereas rivaroxaban, apixaban, and edoxaban inhibits factor 10A, activated 10, and that's why they have the XA in their name. The great thing about the DOACs is that you don't have to monitor them, because once you take them orally, small is guaranteed that the drug is going to be there in sufficient quantities in the plasma to work. It has less food and drug interactions compared to warfarin. It has a rapid onset and offset of action. As a result, you don't need to bridge it with the parenteral anticoagulant like heparin to start. And also, if you want to stop it because of a surgery or an emergency or bleeding, again, there is no need to bridge or give a reversal agent. So those are the advantages of the DOACs. And however, although you don't need to monitor it, there are instances when you do need to monitor it, and it is not easy and not freely available. In Sri Lanka, it's not available at all. And reversal also is complicated because the precise reversal agents for both, we are not available, but we do have an alternative with which we can manage. Something to remember is that there are no head-to-head comparisons between the DOACs. So it is difficult sometimes when you're choosing a particular DOAC to know which one to choose. We have two DOACs available right now in Sri Lanka. So rivaroxaban and apixaban. We have the original versions as well as the generics. The original versions are not registered. They are the hand-carried ones. Then you have the generics, and we'll come back to that later. So the initial part of my talk is that we have to remember that it is not efficacious or safe in all scenarios, which brings us to the initial part where I talk about the good, the bad, and the ugly of DOACs, inspired by this Western classic from the 1960s about three fighters who are good, bad, and ugly. Right, so let's see what is good. These indications we know are definitely good. There is very strong randomized control trial data to say that for these indications, a DOAC should be your first choice. So prevention of venous VTE after elective orthopedic surgery, mainly knee and hip replacement. Treatment for a new acute VTE, so during the initial phase, that is either 3 to 6 months. Then beyond 3 to 6 months, extended period of venous thromboembolism at a lower dose, there's good evidence. Stroke prevention in atrial fibrillation probably has the strongest evidence for the DOAC against warfarin. Then prevention of VTE in patient groups such as patients with active cancers, acutely medically ill patients. And finally, there is an indication for rivaroxaban at a very lower dose in prevention of arterial disease, especially coronary artery disease, as well as peripheral artery disease. So indications for these are clear-cut, and there's no real argument whether you can use it or not. So let's look at the evidence for DOACs in atrial fibrillation. So these are the four cardinal trials, so the Rely, Rocket, Aristotle, and Engage. And if I can put your attention to this, so if you look at the mean CHAD score of these patients, they're not so high. So they are not so high risk CHAD score patients. And the third row, you will see this figure called mean time in therapeutic range. So that is an important thing because this time in therapeutic range is for patients who are on warfarin, which basically tells us over about a year how long the patient has spent the INR between 2 and 3. Now, more than 70 is desired. So you will see, except for the rocket trial that had rivaroxaban, the other trials had quite decent time in therapeutic range. So the comparator of these, the DOACs, were against a pretty good population of patients who are on warfarin, who are generally having the INR between the therapeutic range. All these trials are non-inferiority trials. So we know that the DOACs are not better than warfarin as an anticoagulant, obviously, because they only inhibit one factor, whereas warfarin inhibits 4 factors. All we know is it is as good as warfarin in terms of an anticoagulant for this particular indication, atrial fibrillation. What about the safety? This is another good thing about the DOACs. So right at the bottom, you will see all 4 DOACs were safer compared to warfarin in terms of intracranial hemorrhage and hemorrhagic stroke, which are both problems when it comes to acute stroke after atrial fibrillation. However, so this is the intracranial bleeding. However, the GI bleeding risk, except for apixaban, edoxaban, and rivaroxaban, and even dabigatran in the higher dose, had a higher risk of GI bleeding, which needs to be kept in mind again once when you're starting a patient on a particular anticoagulant. Right. So this indication of atrial fibrillation can be extended to patients who have acute coronary syndromes or have undergone a percutaneous intervention where they need to be on dual antiplatelets. So quite often they are on triple therapy, what we call anticoagulants, so either DOAC or warfarin with aspirin as well as a P2Y2 inhibitor. Now, the ideal scenario from a hematologist's point of view that will give you the right balance in terms of bleeding risk would be the patient only to be on a DOAC and P2Y2 inhibitor, because triple therapy has a substantial risk. About 1/4 will have a major bleed during an year. So that's a high number, especially if you look at the whole population, this is indicated. So something to remember is always make sure if the patient is on a triple therapy that you use the lower dose of the DOAC. So if it is rivaroxaban, you have to use the 10 milligram dose. Apixaban, it will be 2.5. Right, moving on to the other very strong indication for DOACs is in venous thromboembolism. So again, the 4 DOACs were compared to warfarin and were found to be equally effective in preventing recurrent symptomatic VTE. So these are patients who already had VTE, preventing recurrences of the VTE. And they were equally effective with more or less the same bleeding risk with regards to major bleeding as well as minor and non-clinical minor bleeds. Right. The third one is prevention and treatment of patients who are having acute cancers. Now, this is a major problem because for some time, maybe about 5 years, it was shown that low molecular weight heparin was far superior to warfarin when it comes to treating venous thromboembolism in patients with cancers, which is not a surprise because cancer patients are not very good candidates to have warfarin because of the problems with vomiting, their drug interactions, difficulty in diet, and so on. So since about 2016, the recommendation was if someone with an active cancer had VTE, they should be treated with low molecular weight heparin for at least 6 months or till the cancer was active. So then all the DOACs were compared to low molecular weight heparin, and this is what they found. This diagram is from a meta-analysis of patients with cancer and DOACs. So compared to dalteparin, it's a low molecular weight heparin. And the recurrent VTE was actually similar, or in this meta-analysis, of course, it's actually lower than dalteparin, with more or less similar major bleeding as well as clinically relevant non-major bleeding. So the evidence is very clear. When it comes to active cancer and an acute DVT, the DOACs are preferred anticoagulant. And patients with active cancer who are going to start a DOAC because as prophylaxis, primary prophylaxis, also there's an indication to give DOACs. But there is a caveat. If you remember the atrial fibrillation trials, except for apixaban, they all had a high GI risk. So therefore, the caveat is you can use a DOAC, but if the cancer involves the mucosal surface, such as the GI tract or the GU tract, probably there should be caution because there might be increased bleeding. Right. So that's all for what is the good for DOACs. So now we come to the bad. So splanchnic vein thrombosis. So we are talking about portal vein thrombosis, superior mesenteric vein thrombosis, splenic vein thrombosis, and thrombosis involving the hepatic veins. Now, the problems you have with splanchnic vein thrombosis is that sometimes you're not sure whether it's acute or chronic. You know, if it's an acute splanchnic vein thrombosis, you have to anticoagulate. If it's chronic, probably you might want to, or you probably will have to think about the underlying risk factors. And most of these patients might have cirrhosis or chronic liver disease, which causes anticoagulation more busy. So when it comes to DOACs and splanchnic vein thrombosis, there isn't a lot of good evidence, one RCT and many observational studies. And unless you have an underlying disorder like antiphospholipid syndrome or myeloproliferative neoplasm, you would initially only anticoagulate them for a short period of time. And here also, because of this lack of evidence, most of the guidelines would probably say you can use a DOAC if the patient can't tolerate warfarin, but it's certainly not your first choice because due to the lack of evidence. The report trial, which was a slightly recent one, which looked at rivaroxaban in patients with chronic portal vein thrombosis, was quite promising because it showed that there was benefit. But again, very early evidence, small sample size, we probably need more evidence for us to be confident to start these patients in with splanchnic vein thrombosis on a DOAC. Then we move on to cerebral venous sinus thrombosis, another tricky situation, mainly because it's a venous thrombosis. Not most, but a substantial amount, about 30 to 40% of patients will have associated intracranial hemorrhage. And it is very clear that although there's an ICH, you should not, it's not a contraindication to anticoagulate. You should start anticoagulation because the cerebral venous sinus thrombosis, if it progresses, it will worsen the intracranial pressure and the outcomes will not be good. So therefore, standard practice is always to start with the heparin. And again, the data for DOACs, even after this initial period of heparin anticoagulation, is very flimsy. RCTs are there, small sample sizes with little benefit. And also, the second problem with cerebral venous sinus thrombosis, you're not really sure when you should stop. Some people give it for about 6 months and see whether there's recanalization, or some do continue because there's some evidence if there's poor recanalization, the outcomes are bad. So these kind of patients might be on anticoagulation for a long time. And in those circumstances, DOACs would be a good choice, but again, the evidence is not so great. This is probably a common problem you might come across in your practice, patients with left ventricular thrombus. Again, an area where we don't have a lot of evidence. This, if I can show you the first one, it is a combination of RCTs that showed, the one in the middle, it's a pooled analysis of 3 trials, showed that DOACs, no one particular DOAC, but there were a combination, was probably as effective as warfarin in patients with left ventricular thrombus, and also it had less amount of major bleeding. So there is a little bit of evidence. You might be able to start a DOAC, but again, probably won't be your first choice. And I think that is the practice right now in Sri Lanka. Also, warfarin is the first choice for this. But with time, hopefully, DOACs might come into that picture. So this is for patients who already have a thrombus, and the one the right at the bottom you see a trial which is not published yet, where they're looking at rivaroxaban 15 milligrams giving as primary prevention of anterior ST lesion MI to prevent LV thrombus. Right. Then area where really we don't talk about it or think about it much is catheter-associated VTE. Now, this is another area where DOACs evidence is not so great. The reason we'll come back to later when we are talking about the mechanical valves. Again, there is a few trials and also which has shown that they may be associated with good outcomes. But the important thing is most of this patient population who get catheter-associated thrombosis are patients with cancer. And these, but if you can recall what I said right at the beginning, the evidence for cancer-associated thrombosis is pretty good for the DOACs. But the subgroup analysis of all those trials are not available except for the AVERT trial, which showed when they looked at the patients who had active cancer and had acute DVT, and out of that population, you take out the population who had catheter-associated DVT, there was a good outcome shown there. But the other trials, they did not show the subgroup analysis of this particular population. So again, you have a patient with a central venous catheter with a VTE. You should not hurry too much or jump and start a DOAC immediately, because you should be aware that the evidence for that indication is not so strong. Right, coming on to the ugly part, where you know that the evidence is bad. So these are the 4 indications that the DOACs have not at all shown benefit as against warfarin. So presence of mechanical heart valves, rheumatic valvular heart disease. I mean, we are talking about severe to moderate mitral stenosis really, antiphospholipid syndrome, and also transarterial aortic valve replacement. What do we know about mechanical heart valves? There were 2 clinical trials, one for dabigatran and one for apixaban. Both had to be terminated early because the high rate of thrombosis. The third one, the Renovate one, is ongoing, where they are looking at rivaroxaban against warfarin, in particular aortic valves, because they think because of the high flow, there's a lower risk of thrombosis there. So mechanical heart valves, either with or without atrial fibrillation, DOACs have no place. Right. Now, the possible explanation they give here, now if you remember, it's not effective in mechanical heart valves, it's not effective in VTEs with associated central venous catheters or left ventricular assisted device. All of these have one thing in common. That is, there is some foreign substance with in contact to the blood vessel. So the explanation is, if you remember your old explanation of the coagulation cascade, you have your extrinsic pathway on this side, which is activated by tissue factor, which is produced by the endotheliums or monocytes or inflammatory cells, activate the extrinsic pathway, and factor 7 is activated. Factor 7 activates factor 10. Whereas the intrinsic pathway is activated by what we call contact factors, clotting factors coming into contact with artificial substances like glass, which was classically there in the lab, and that activates the intrinsic pathway and activates factor 10. So if you look at warfarin, which is shown in this salmon pink color, it shows that it is active in the extrinsic pathway, intrinsic pathway, as well as the common pathway. Whereas direct DOACs are only active here in the common pathway. So this is the explanation they give for why DOACs are doing pretty poorly in these instances. I don't agree with this completely, because now this is a very old-fashioned explanation of the coagulation cascade. We don't even call it a cascade. So we talk about initiation, propagation, and amplification. But it's a nice explanation to give some sort of reason for why DOACs are doing poorly in this group. Antiphospholipid syndrome, again, I think the evidence is pretty clear. Rivaroxaban and apixaban have tried against vitamin K antagonists, and that has shown that the outcomes are not good. It is especially possible, the outcomes are especially poor if you're having arterial thrombosis and antiphospholipid syndrome. Venous thrombosis probably not as bad. So most guidelines tell that if you have antiphospholipid syndrome and arterial thrombosis, that you should not start a DOAC, or if the patient is already on a DOAC, you should change it to warfarin. They also talk about this triple positivity there. If you have a positive of lupus, cardiolipin, and beta-2-glycoprotein, those are what we call triple positive APS. That population also is high risk and probably should not go on a DOAC at all. But there's a meta-analysis on these antiphospholipid syndrome trials that did not show that triple positive was such a bad risk factor. However, I think the current practice is, so if you diagnose somebody with antiphospholipid syndrome and a VTE, if you are triple positive, you convert it to warfarin if the patient is already on DOAC. And if it's antiphospholipid syndrome with an arterial thrombosis, again, no DOACs, but only warfarin. Right, so that brings an end to the first bit of the talk. I think I'm doing okay on time, and there is a question here. Right, so it's a big, lengthy question. I'll take it probably at the end. Okay, right. Okay. I'll go back and forward. Right. So when you have the choice of starting a patient on a DOAC, this is the sort of the questions that go through my mind. The first question to ask is a DOAC going to be effective in this patient? And that's what we try to answer in the first part of the talk. You have your solid evidence ones, the ones you don't want to start, and of course the ones with iffy evidence. Then always assess the bleeding risk, not to really stop anticoagulating, but to correct any bleeding risk factors. Calculate the creatinine clearance, look for drug interactions, think about the cost, access to reversal agents, and also consider the patient's lifestyle. So this, I think we've gone through in quite a bit of detail, so you know when you should not use a DOAC. Two additional points to remember is right now, it's not proven the safety to be used in pregnancy or breastfeeding. However, in patients being prescribed DOACs while they are breastfeeding. So probably the message hasn't gone through yet. And also extremes of body weight. If body weight of more than 120 or BMI of more than 40 or extremely low body weight, again, these patients were not at all involved in those pivotal trials, so the evidence is less. Body weight more than 120, probably rivaroxaban has some evidence, but again, these are something to consider right at the beginning. Is DOAC going to be effective for my patient? Second one, assess the bleeding risk. So here, it's always good to use some sort of a structural score. I commonly use the Hasbled score. And like I said before, this is not to look for contraindication for anticoagulation, but rather to see if there are risk factors that can be corrected and you can bring the bleeding risk down. So the Hasbled score, which was originally designed for patients on warfarin, looks at hypertension, abnormal liver or renal function, history of stroke, active bleeding, lay-by INR, age more than 65, if the patient is on drugs or alcohol. So each point increases the risk. And like I said, it needs to be modified. And if your score is more than 4, that puts you at substantial risk. And this is a large Swedish population study on oral anticoagulation. And if you look at the graph on the right side, you'll see that when the Hasbled score goes above 4, that's when the risk of ICH goes up. So again, things like controlling the hypertension, correcting abnormal renal or liver function, stopping drugs or alcohol, or all these things that are modifiable and can substantially reduce the risk. Right. Number 3 is adjustment based on renal clearance. So all the clinical trials that were done on DOACs were done using the calculated EGFR. So you have to calculate, not use the estimated EGFR, but to calculate the Cockcroft curve. I mean, you can use MD calc to do that. It takes just less than a minute. But once you calculate it, there are some important things to remember. One is if the creatinine clearance is more than 90, edoxabam should be avoided. We don't have edoxabam in this country right now, but edoxabam is the cheapest of all the DOACs, so probably it will be available. And if it becomes available, it might be popular because of the price. But having a creatinine clearance of more than 90 is not unusual. So therefore, you have to be careful not to start anyone who, because the clearance is, when the creatinine clearance is high, the drug is probably not effective. Well, for the others, once the creatinine clearance comes below 30, you can use a lower dose except for dabigatran, but anything below 15, it is contraindicated. Okay, right. Then drug interactions. Compared to warfarin, I mean, this was one of the major advantages of the DOACs, but that it has very minimal drug interactions. But you have to remember, all the DOACs are metabolized or have the action of P-glycoprotein, which is a surface molecule that regulates drug influx and efflux. So any drugs that has either inducers or inhibitors of P-glycoprotein will have an effect on your DOAC levels. Apixaban and rivaroxaban, in addition to P-glycoprotein, is also metabolized by cytochrome 3A4 enzyme. So any drugs that are inducers or inhibitors of that, probably you should not start. This is a good reference, the European Heart Association guidelines. There are about, excuse me, there are about 4 papers on DOACs, and in one of them, there is a very extensive list of the drugs that should be avoided in patients with DOACs. Right, the cost and access to reversal agents. So like I mentioned before, we have generic forms of DOACs for apixaban as well as rivaroxaban, and they are generally affordable. It costs about around 150 to 200 rupees. And more importantly, now it has been added to the list of drugs. So both apixaban and rivaroxaban has been added. So it might be available in the government sector as well. You can go for original brands, but they are not registered. These are all from the hand-carried versions. But by this year, all the DOACs will use their exclusivity, and there'll be lots and lots of choices to choose from. Now, among the 4 DOACs, dabigatran is not very popular. It's mainly the other 3 that has popularity. There are several things. One is the dose is a bit cumbersome. You're really not sure whether it's 110 or 150. Dabigatran is a very large tablet. You can't break it, you can't crush it. So it's not very popular. The only instances you really have to go for dabigatran is when it comes to drug interactions, where certain things like protease inhibitors in HIV positive patients, probably dabigatran is the only one you can use. So few indications, not very popular and not available at the moment also. Right. Then reversal agents. So when it comes to specific reversal agents, there are 2 specific reversal agents. Idarucizumab is a monoclonal antibody against dabigatran. Adexinet alpha is, as the name suggests, is the antidote for the anti-10A inhibitors. It is not a monoclonal antibody. It basically competes with the 10A inhibitors for excretion. So it fills all the excretion pathways, so your natural anti-10A increases. These are very expensive. Adexinet alpha is like exorbitant. You need a bolus and an infusion, very expensive. I don't think it will be available here at all. But in the absence of these specific agents, you can use PCC, so 4-factor PCC, 25 to 50 units can be used. And generally my experience, I don't have a lot of experience, but you can generally control bleeding with DOACs with PCC. You can even not go for this dose, but just give 1 ml of PCC and usually things settle down. Because, I mean, the duration of action is less, so you just have to survive 6 hours or so. So on that subject, I will give a brief revision of what to do when a patient is bleeding. So very importantly, you have to keep in mind 2 factors. When the patient took the DOAC, because the half-life is extremely important, and also the creatinine clearance. So depending on that, you can basically assume how long the drug is going to be in the patient's circulation based on these 2 factors. If it's a minor bleeding, you just need to support the patient during that hour with local pressure or fluid resuscitation. If it's non-life-threatening major bleeding, again, you can try your supportive measures such as fluid replacement or blood platelets if the platelets are low. You can do mechanical compression, get the surgeons or the ENT surgeons or the interventional radiologist involved to local control the bleeding. And of course, you can use tranexamic acid can be used. Again, caution for bleeding involving the GU tract as well as the GI tract. GI tract, because there was this randomized control trial called the HALTED trial that showed the outcomes with patients with massive GI bleeding and tranexamic acid. The outcomes were not very good. And I have also actually seen it myself, where patients with GI bleeds and tranexamic acid can sometimes get nasty thrombosis like MIs and stroke. I don't know the reason why. Then life-threatening bleeding, really, we only have the option of PCC. Beriplex is the brand. You can just give 1 vial because it's very expensive again. And usually things settle down. Right. Then finally, you can always customize your options for a patient. So, you know, rivaroxaban is a drug that is taken once, whereas apixaban, you have to take it twice a day. So the patient might want to take once daily or twice daily dose. Apixaban and rivaroxaban does not need low molecular heparin cover up front. You just need to give a higher dose at the beginning. When it comes to apixaban, it's 7 days, whereas rivaroxaban, it's 3 weeks. So that might be something that to consider once when you're choosing between the DOACs. Remember, rivaroxaban has to be taken with food, otherwise the bioavailability reduces by about 30 to 40%. Some patients with DOACs experience this minor nuisance bleeding, such as gum bleeding, nose bleeds, heavy menstrual blood loss. I mean, it's not really bad bleeding, but it's really annoying. So the recommendation for that is to give a BD DOAC rather than a once daily, because when you give it once daily, you get high blood values, whereas a BD dose is much smoother. But my experience and also other hematologists in Sri Lanka I have mentioned that we see this sort of nuisance bleeding with apixaban for some reason, which is given twice daily, and less with rivaroxaban. Probably what should not be expected. Then you can crush all the tablets. You can give it via NG, except for dabigatran. And I mean, then this risk of overdose or rivaroxaban is probably safe if there is a risk of overdose, because it has a ceiling effect. So even if you take a huge number of tablets, I mean, it's still toxic, but because of the ceiling effect, it might not cause such a bad coagulopathy. So these are little things to consider when you're choosing between rivaroxaban and apixaban for your patients. So the doses, so for rivaroxaban, the standard dose is 20 once daily. So you start with 15 BD for 3 weeks, and you go on to the 20 dose. If the EGFR is between 30 to 15, you can go for a lower dose. The prophylactic dose is 10. So extended anticoagulation beyond 6 months will be the 10. Then there's of course there's this 2.5 BD dose of rivaroxaban, not to be confused with the apixaban dose, which again I have seen happening. So this 2.5 BD dose is given for these vascular pets who have multiple arterial problems like coronary artery disease, carotid artery disease, peripheral artery disease. So there's a trial that showed that these patients benefit by taking lower dose of rivaroxaban. Apixaban standard dose is 5 BD. 2.5 is the reduced dose. If you have 2 of these, either the age, body weight less than 60 or creatinine clearance more than, so 2 out of the 3, you go for the lower dose, or if you have creatinine clearance less than 30, again you go for the lower dose. I will probably not talk about dabigatran and rivaroxaban because they are not available. These are the ones that we have at our disposal. Okay, so I think this is also on the dosing. Right, then how do you switch a patient who's on vitamin K antagonist to DOAC? So if the patient is already established on warfarin, you stop the warfarin, check INR after about 2 days, and once the INR comes to below 2, you can start the DOAC immediately. If the patient is on an unfractionated heparin infusion, you just stop the infusion, wait for 1 hour. After that, you can start the DOAC. If the patient is on low molecular heparin, you just start the DOAC at the next low molecular heparin dose. When the next low molecular heparin dose is due, you start the DOAC. Right. Finally, follow-up. So always, as you would do with any anticoagulant or antiplatelet, educate the patient about the high risk of bleeding. Give them sort of some documentation to tell that you're on an anticoagulant and specifically a DOAC because of the possible drug interactions. You would probably want to see the patient after about a month starting and then 3 monthly. At each visit, always review the indications because the indications change, the evidence change as we discussed right at the beginning. Check for bleeding, new thrombotic events. Good habit to check for the platelet count, hemoglobin, LFTs, and renal function. And also any new drugs that has been started that can have an effect on the DOACs, and also compliance and any new unwanted side effects. Yeah, I think that's the end of the talk. So like I mentioned, there's this 3 or 4 very good articles from, it's quite old, from 2018 by the European Heart Rhythm Association, but very practical, easy to follow advice if you are frequently prescribing DOACs in patients. So once again, thank you very much. Thank you, Ranga and Dr. Suranga, for giving me the opportunity. I think there are a couple of questions I can take. Okay.
Thank you, Manu. Thank you very much for your comprehensive and excellent talk. I'm sure our audience has much benefited from your talk. We have one question from Dr. Madhuvanti Hettiarachi. If the patient has got a very extensive DVT due to extensive lymph nodes pressing IVC, non-Hodgkin's lymphoma within brackets, do you recommend subcutaneous enoxaparin in the initial phase over DOAC, or do you still recommend DOACs as the initial treatment? If the patient was already started on enoxaparin for 1 month, how would you advise to continue with DOACs, and how long should it be continued?
All right. Yeah. So there's 2 issues. One is, of course, this is a cancer-associated thrombosis. We shouldn't forget that. And there's an extensive DVT. So in terms of cancer-associated DVT, we know the evidence is equally good for enoxaparin and all the DOACs. But I would also be a little bit uncomfortable when it comes to these very extensive DVTs because the evidence is not that great. when it comes to these very extensive ones. I mean, if it's really symptomatic, if it's in the very initial stages of 2 weeks, I would always do a vascular referral to see if they can retrieve the clot. Because, for example, if it's a young patient with a very extensive DVT of the lower limbs, I mean, long-term morbidity can be pretty nasty. So that's something I would do. And I would also definitely, at least for about 6 weeks, give the patient subcutaneous enoxaparin. Yeah, do you recommend DOACs? Yeah, I mean, I would be a bit uncomfortable really to give a DOAC unless the patient is really averse to getting the subcutaneous injections. How would you continue? So I think after 1 month to 6 weeks, depending on the symptoms, etc., you can switch to a DOAC because the evidence is pretty good. How long? As long as the active cancer is there. So until the patient is in remission, patient should be on the DOAC. I hope that answers your question, Madhuvanti.
Okay. In the absence of any questions, I would like to thank Dr. Manu Wimalachandra, consultant hematologist from Faculty of Medicine, University of Dr. Dilukshi Pilapiti has raised the hand. Dilukshi?
Hello.
Yes, you
Hello.
can speak. Yes. Yeah.
Yeah, sorry. Yeah, I'm a nephrologist, so I'm wondering whether, because in the lecture it was told that less than GFR 15, it's totally contraindicated. But I've seen people use apixaban when the GFR is less than 15. I just wanted to hear your thoughts on that.
Yeah, I mean, contraindicated is contraindicated. No, I mean, there's nothing called totally contraindicated.
Yeah.
The problem is the options are very limited to us, isn't it? When you have patients with end-stage renal failure, the recommendation and the evidence is obviously because I think I showed there was a slide, there's quite a big renal clearance and less than 15, there's a high risk of bleeding. So, I mean, even if you use the lower dose, that risk is there. I don't know whether there's a right answer for that.
All right. Thank you.
Are there any questions?
There is one, I think.
Yeah.
Yeah.
What is your experience between original brand over generic brand?
So I have used, I haven't got a lot of experience with generic for apixaban, but the other one, I think there's about 2 or 3, I haven't seen any problems. I haven't seen any recurrent VTs for those who are on the generic. So I would use it without much, of course, give the option to the patients. Some might want to use it because, I mean, it's not that it's completely unaffordable. Some people might be able to afford that. But my experience is good, in short, yeah, with the generics.
Ranga, I have a question.
Yes, Dr. Manu. Yes.
Manu, thank you for your excellent talk. So is there any indication for DVT prophylaxis? Usually we give enoxaparin for prophylaxis. Is there any indication?
As in with DOACs, is it?
Yes. For prophylaxis.
Yeah, of course. So all the DOACs have a prophylactic dose. So for example, rivaroxaban in 10 milligrams is the prophylactic dose, and apixaban in 2.5 is the prophylactic dose. So just like you give 40 milligrams of enoxaparin as prophylaxis for a medically ill patient, or maybe someone who has active cancer. You can give one of the ones, but edoxaban does not have a prophylactic dose. Only apixaban and rivaroxaban has.
Okay. Thank you.
Thank you very much, Manu, for your excellent talk. And I'm sure that our audience has much benefited from your talk. And with you accepted our invitation without any hesitation. And on behalf of the President and the Council of Sri Lanka College of Internal Medicine, I thank you again for your excellent talk on DOACs. And let me thank the President and Council for allowing to conduct the therapeutic forum for the beneficial of our own physicians, as well as the Gates Pharma for sponsoring this event. Thank you all, and good night.
Thank you. Good night.
Thank you. Thank you.